Hi everyone, it's me, Mr. OD. I'm here to lecture on Chapter 25 for our EMT class here at Monroe 1 BOCES EMCC. It's in the textbook Emergency Care and Transportation of the Sick and Injured. Again, Chapter 25, Bleeding. We need to know about bleeding and recognize bleeding and understand how it affects the body. Bleeding can be external, meaning we can see it outside the body, or internal, meaning we can't see it, it's inside. But we can also sometimes see signs of internal bleeding, like discoloration of the skin, distension of the portion of the body, most likely the abdomen. Bleeding can cause weakness, shock, which is lack of perfusion to tissues, or hypoperfusion, and eventually death. Bleeding comes under our ABCs under C. Circulation, making sure that we have a pulse, our skin color, condition, and temperature, and then finally hemorrhage control, or making sure people are bleeding. Anatomy and physiology of the cardiovascular system. We're going to review how blood circulates through the cells and tissues of your body, why it's important to get oxygen and nutrients to those cells, and talk about the metabolic waste products, carbon dioxide. Here is the anatomy and physiology of the cardiovascular system. As you can see at the top, you see the superior circulation and the inferior circulation below it, the pulmonary circulation and the central circulation in the center. Three parts. You have your pump, which is your heart, the container, which is all the blood vessels, the veins, arteries, arterioles, venules, capillaries, and the fluid, which is the blood, made of the different components that make up blood, which are erythrocytes, plasma, and platelets. Your heart needs a rich and well-distributed blood supply. It works as two paired pumps. The upper chambers are called your atrium or your atria. Atrium is singular, atria is plural. Your lower chambers are called your ventricles. Remember, your right side is oxygen poor and carbon dioxide rich. Your left side is carbon dioxide poor and oxygen rich. Remember that blood is never blue, but we often describe in diagrams the blue meaning oxygen poor and the red meaning oxygen rich. Remember, your aorta is the largest artery of your body and ejects blood from that left ventricle. That left ventricle you can see in the diagram is that thick bottom chamber of the left side of your heart, because it has to eject blood from here and get to all portions of your heart, of your body, all the way to your brain, and then all the way to your little baby toe. Types of blood vessels. We talked about arteries that carry blood away from your heart in most cases, arterioles that connects the arteries and capillaries, capillaries that link arterioles and venules, veins that empty into your venules that empty into your veins, and veins that carry blood from the tissues to your heart. Remember, capillaries are where exchange happens, where our bodies are able to drop off that oxygen from that's bound to any of the erythrocytes' hemoglobin, pick up carbon dioxide, and then using the venules and veins return back to the right side of the heart so that it can go to the lungs to drop off the CO2, pick up the O2, and then go to the left side where it will be then recirculated throughout the body. Oxygen and nutrients pass from the capillaries into your cells, and the waste carbon dioxide diffuses into your capillaries. You can see here exchange happening where you have your pulmonary venules and your pulmonary arterioles. And you also have these are your lung alveolar capillaries. Again, exchange happening here, oxygen and nutrients into your tissues and CO2 and waste back into your circulation to be returned to the right side of your heart. Blood contains red blood cells, white blood cells, platelets, and plasma. Clots form depending on several factors, all to do with usually platelets and a clotting cascade that we will talk about, but platelets play a large part in your body's ability to clot. You can see the different shapes of white blood cells, red blood cells, and platelets here. Platelets are these little bitty dots. Red blood cells are these donut-looking things, and white blood cells are these bigger type pink, larger cells that are suspended in your plasma of your blood. Your autonomic nervous system monitors the body's needs. It adjusts blood flow, and it automatically redirects blood to the heart, brains, lungs, kidneys in an emergency, and adapts to maintain homeostasis, or that internal balance, so that perfusion gets to all your necessary organs, tissues, and cells. Pathophysiology and perfusion. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. Remember we talked about this story about going to Wegmans but never taking out the trash? Well, the arterial system basically is you going to Wegmans, getting your oxygen and nutrients. You go outside to get oxygen. You go into Wegmans to get food and nutrients. You bring them home. But eventually you'll have to take out the garbage. If you don't take out the garbage, your house will be full of garbage, and eventually you'll have no place to live. Therefore, you will die. Same sort of scenario. We can make that association with our blood circulation. We need oxygen from our lungs. We need to deliver it to our homes or our cells, our tissues, and our organs, and we need to take out the waste after we are done dropping off those products needed to maintain homeostasis. Some tissues need a constant supply of blood, while others can survive with very little. All organs and organ systems are dependent on adequate perfusion to function properly. Death of an organ system can quickly lead to death of the patient. Hemorrhage means bleeding. You see the word hemo in the prefix there. With RRHAGE meaning running, so blood running, hemorrhaging, bleeding. With serious external bleeding, it may be difficult to estimate the amount of blood loss. Blood will look different on different surfaces. For example, if you bleed out on a concrete slab versus if you bleed out in grass versus if you bleed out on a tile floor versus carpet, etc., it will all look differently. Hard, non-porous surfaces will look like more, and soft, porous surfaces like grass and carpet will look like less. It's important to estimate the external blood loss. Your body will not tolerate a blood loss greater than 20% of its blood volume. Changes in vital signs may occur with significant blood loss. They include an increase in heart rate, or the patient should be tachycardic with a heart rate above 100, a decrease in respiratory rate, and a decrease in blood pressure below that 120/80, which is our gold standard perfect blood pressure. Not all patients that have a blood pressure below 120/80 are hypotensive or hypoperfusing. It definitely depends on the patient's normal. How well people compensate for blood loss is related to how rapidly they bleed. An adult comfortably can donate 1 unit or 500 milliliters of blood over 15 to 20 minutes. If a similar blood loss occurs in a much shorter time, the person may rapidly develop symptoms of hypovolemic shock. One of our types of shock, remember shock means hypoperfusion to tissues or hypoperfusion in general. Consider the age and the pre-existing health conditions of the patient. Arterial bleeding usually causes bright red squirts of blood. Typically it's brighter and squirts in time with the pulse. Pressure causes blood to squirt and make bleeding control more difficult. Venous bleeding is more dark red. It does not spurt. It's usually easier to manage, and it's usually just a leaking or a dripping versus a squirting. Capillary bleeding, bleeding from damaged capillary vessels. This is what happens when we take someone's blood sugar. We induce this capillary type bleeding. Up here you can see some venous bleeding and then some arterial bleeding down here. This hockey player had his carotid artery severed by a skate, and you can see the blood squirting all over the ice. Clotting. Bleeding tends to stop rather quickly within about 10 minutes. When the skin is broken, blood flows rapidly. The cut ends of the vessel begin to narrow, reducing the amount of bleeding. A clot then forms. Bleeding will not stop if a clot does not form. It's important that that we stop and manage people's bleeding. Clots are our body's natural way of stopping bleeding. People that are on thinners like Coumadin, warfarin, etc. will definitely bleed more and not clot as easy. Also, folks that have underlying genetic disorders like hemophilia do not clot as easy. Patients, because they lack blood clotting factors, bleeding may occur spontaneously even, or just by bumping into a side of a table or a door, etc. All injuries, no matter how trivial, are potentially serious to folks that have hemophilia. Again, genetic hematological disorder. Patients should immediately be transported to a hemophilia center or the closest hospital. Internal bleeding, bleeding in a cavity or space inside the body, can be very serious because it's not easy to detect. Injury or damage to internal organs commonly results in extensive internal bleeding, which can also lead to hypervolemic shock or hypoperfusion to tissues. Internal bleeding again, conditions causing internal bleeding could be stomach ulcers, lacerated livers, ruptured spleens, broken bones, especially your ribs and femur, and pelvic injuries. High energy mechanism injuries, like we talked about in chapter 24, should increase your index of suspicion for serious injuries. Internal bleeding is possible whenever your mechanism of injury suggests that severe forces affect the body, and you're looking for signs of decap TLS, deformities, contusions, abrasions, punctures, penetrations, burns, bruising, tenderness, laceration, swelling, or any other signs of injury. NOI, nature of illness for internal bleeding. Bleeding is not always caused by trauma. It can be caused by medical conditions like bleeding ulcers, a bleeding from your colon or a GI bleed, ruptured ectopic pregnancy or a tubal pregnancy, or aneurysms, the weakening of the lining of your blood vessel that eventually could burst or rupture. Signs and symptoms of internal bleeding include pain, swelling in the area of bleeding, distension, dyspnea or trouble breathing, tachypnea or rapid heart rate, hypotension, low blood pressure, hematoma, which is a fancy term for bruising, bleeding from any body opening. Hematemesis is the fancy term for blood in your vomit. Hema meaning blood, emesis meaning vomit. Melena is this dark, tarry stool, usually as a result of a GI bleed or gastrointestinal bleed. It smells terrible. It is dark black and it's gross. Pain, tenderness, bruising, guarding, or swelling. Guarding is when a person tries to protect their abdomen or internal structures because they are hurt. Broken ribs, bruises over the lower part of their chest and or rigid distended abdomen, and then obviously hypoperfusion. Decreased capillary refill. Remember, when you squeeze your nail bed, that capillary refill bed should turn back less than 2 seconds, or low blood pressure. Scene safety, be alert for potential hazards, follow standard precautions, determine mechanism of injury and nature of illness, consider the need for spinal immobilization and additional resources. Primary assessment, do not be distracted from identifying life threats. Form a general impression, perform your rapid exam, address life-threatening bleeding. Remember, direct pressure, pressure dressing, tourniquet, treat for signs of hypoperfusion or shock, lay them down, keep them warm, give them oxygen, rapid transport to a nearest most appropriate facility. Determine their level of consciousness, alert, verbal pain, unresponsive. Make sure they have an airway, provide high flow O2 or assisted ventilations as necessary. Oral adjuncts for unconscious patients. Nasal adjuncts are also appropriate depending on if the person has sustained trauma, head trauma. Remember, NPAs are contraindicated in folks that have had head trauma. Circulation, assess the pulse rate and quality, determine the skin condition, color, and temperature. Control external bleeding, again, direct pressure, pressure dressing, tourniquet if necessary, lay them down. You can put them in Trendelenburg, which means their feet go up. Minimal signs of, minimal research on Trendelenburg actually being effective. It's anecdotal practice. It sounds like a good thing to do, so a lot of folks do it still, but not much research on saying elevate their legs being much of a help. And treat for signs of shock, keep them warm, lay them down, give them oxygen, rapid transport. Determine the transport priority. Remember that golden hour of trauma being 10 minutes. We want to load and go. They need bright lights and cold steel. Signs that imply rapid transport include tachycardia or tachypnea, fast heart rate or fast breathing, hypotension or low blood pressure, weak pulse, and pale, clammy, cool skin. Using sample, we're going to take some history to signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and the events leading up to. Investigate their chief complaint. Ask the patient about blood thinning medications like Eliquis, Coumadin, warfarin, etc. If the patient is unresponsive, obtain a history from a medical alert tag, bystanders, or that ICE thing in their iPhone or Android devices. Also, sometimes there's vial of life or history things that people keep on their refrigerator or just inside their refrigerator given out by local ambulance companies, so be aware of those. Great in case of an emergency and the patient can articulate their history. Secondary assessment, get some blood pressure. Systolic blood pressures of less than 100 millimeters of mercury with a weak rapid pulse suggests signs of hypoperfusion. It is a late sign of hypoperfusion. This person needs to be at the hospital like yesterday. With critically ill or injured patients or a short transfer time, there may be not time to conduct a secondary assessment. Do the best you can. Make sure you're thorough. Do not miss anything. make them dry, make them naked, make them warm. Again, we want to make sure that we don't miss stab wounds or bleeding from places we can't see, especially in their armpits, groin, or back. Assess all areas for decap BTLS. Look for uncontrolled bleeding from large scalp lacerations. Feel all quadrants of their abdomen for tenderness and rigidity. Record their pulse, motor, and sensory functions in all four extremities, their CMS, and look for signs of internal bleeding, discoloration, distension, tenderness. Reassessment of the patient, especially in the areas that shown abnormal findings, should be assessed every 5 minutes. Stable patients can be reassessed every 15 minutes. Communication and documentation: recognize and estimate and report the amount of blood loss and how rapidly over what period of time it occurred. Communicate all relevant information to staff at the receiving hospital. Document all injuries, document all injuries, the care that you provided, and the patient's response to all your interventions. You should follow standard precautions, BSI, making sure you have gloves, eye protection, gowns, etc. Make sure the patient has an open airway and is breathing adequately. High flow O2, 15 liters non-rebreather. Control obvious life-threatening bleeding as quickly as possible. Several methods are available to control external bleeding: direct pressure and pressure elevation, direct pressure dressings, splints, and tourniquets. Again, direct pressure is the most effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation or the formation of a clot to occur. Apply pressure with a glove fingertip or hand over the top of a sterile dressing. Hold uninterrupted pressure for at least 5 minutes. The patient can also help you do that if you're having trouble. Firmly wrap with a sterile self-adhering roller bandage around the entire wound, stretching the bandage tight enough to control the bleeding. You should still palpate a distal pulse, so make sure you do CMS before and after, just like with splinting, making sure that your bandage isn't so tight that it stops the bleeding and effectively becomes a tourniquet. Do not remove the dressing until a physician has evaluated the patient. Once you put it on, you don't take it off. Apply the additional pressure dressings through the dressing. Just add more dressing on top of the first one. Hemostatic agents are any chemical compound that slows or stops the bleeding by assisting with the clot formation. Sometimes we call this quick clot. It's gauze that's coated in inducing clot formation proteins. It catalyzes the formation of clots. Can be used with direct pressure when direct pressure alone is ineffective. Obviously, follow your protocols. Tourniquets are useful if the patient has substantial bleeding from an extremity injury that cannot be controlled by direct pressure and direct pressure and pressure bandages. Several types are available. The CAT tourniquet is the most commonly used. If a commercial tourniquet is unavailable, you can create a tourniquet using a triangular bandage and a stick or a rod. It is, however, not recommended. You should use commercial tourniquets if at all possible. Observe the following precautions. Don't apply tourniquets directly over a joint. Make sure the tourniquet is tightened and secure. Never use wire, ropes, a belt, or any other narrow material. Place padding under the tourniquet. Never cover a tourniquet with a bandage. Do not loosen the tourniquet after you've applied it. And the tourniquet is going to hurt like a son of a gun. So make sure your patient knows that even if they're saying, take it off, take it off, take it off, once you put that tourniquet on, that is staying on, that is saving their life. Their pain will be immense and you will feel bad, but do not take it off. Splints. Air splints can control internal or external bleeding associated with severe injuries, act as a pressure dressing applied to an extremity. Rigid splints like cardboard splints and board splints immobilize fractures and prevent further soft damage. Bleeding from the ears, nose, and mouth. Several conditions: skull fractures, facial injuries, sinusitis, infection, dried or cracked nasal mucosa, hypertension or high blood pressure, coagulation disorders, or digital trauma. Epistaxis is the fancy term for a nosebleed. It's a common emergency. Occasionally can be cause enough blood loss to send a patient into shock. Can usually be controlled by pinching their nostrils together. Bleeding from the nose, ears, or following head injury may indicate a skull fracture, may be difficult to control. Do not attempt to stop blood flow. Loosely cover the bleeding site with a sterile gauze pad. Apply light compression with the dressing. Emergency medical care for internal bleeding usually requires bright lights and cold steel, a surgery, an OR. Keep the patient calm, reassured, and still. and as quiet as possible. Treat for shock, place supine, feet up, high flow O2, keep them warm. And that is it for me. We will see you next time. Please make sure you review the review questions at the end of the slides in your JBL learning management system, and I will see you next time. Ciao for now.